That's the most important thing to know. There's 4 different types. Okay, but most people have acute attacks, and then periods of time where they return to their baseline. Okay, so how do we diagnose it? So you can do a CAT scan, but you will not see as much. So MRI is really the best way to diagnose MS. You'll be able to see damage to the nerves on MRI. Okay, and we do something called evoked potential studies. There's different types of evoked potential studies. One is visual, one is brainstem, which is actually auditory. Okay, and these will show decrease if there's decreased conduction along the nerves. Okay, and then often they'll do a spinal tap on the patient, and the spinal tap will show that there are there's banding seen in the IgG. Okay, so 3 things: MRI, evoked potential, and spinal tap. Okay, so most of these things, for most people, combined with the clinical symptoms, they'll do these tests and they'll make a diagnosis. Okay, so as you can see, there's many, many clinical manifestations. For a lot of people, the first thing will be facial weakness or numbness. And then if you go down to the right side at the bottom under visual deterioration, something called optic neuritis. So this means unilateral visual decrease or loss in one eye, unilateral, often with pain. Okay, so that's called optic neuritis. So facial weakness, numbness, tingling, optic neuritis are often 2 of the more common things that are presenting symptoms.
So could you say that one again?
Facial weakness and then optic neuritis. Okay, and as you go down the list here, you'll see that a lot of people actually end up having some cognitive disorders. So they'll have problems with their memory, judgment, reasoning. Okay, people can get depressed and they don't know if depression, they think there's really 2 components to the depression. They used to think it was just a result of the symptoms, but they are thinking more now that it may actually be a result of the disease process too. So there may be 2 things going on that are contributing to depression. Okay, you'll see a lot of people have bowel and bladder issues, as well as sexual problems. Okay, what's dysarthria? You guys know?
Joint pain.
That's arthralgias.
This.
So it's slurred speech. Okay?
Is that?
Okay, and another word you may not know is oscillopsia, which is it's when objects they look to the patient like they're jumping into their visual field. I think of it like, I've never done heavy drugs, but I would imagine that's kind of the thing that you get. Okay, secondary symptoms. And what do people get after they get, what results from the initial problems? So people can get urinary tract infections. A lot of people actually have to end up catheterizing themselves, so they're more prone to urinary tract infections. Or if they don't catheterize, they are retaining sometimes more often. So we know, you remember from GU, what happens when you retain. You get infection, the urine's hanging out, comfortable, bacteria can multiply. Sorry. Okay, ulcers, how would ulcers happen? Just talking about decubiti, pressure ulcers, how would they happen? So, yeah, so that could contribute to skin breakdown, or if they already had a pressure ulcer, the acid from the urine can make the pressure ulcer worse. Right, numbness, tingling. As the disease progresses, they're often in a wheelchair, so they're going to be more prone to pressure. They're more immobile. Okay, so they will be prone to pressure sores in many different ways. Okay, pedal edema. So they'll have, just from being independent, more likely to have edema. Okay, osteoporosis. So, especially once the women get past menopause, they have sort of a trifecta. They have a decrease in estrogen from menopause. They have immobility, right? Okay, and we know that one of the things that prevents osteoporosis is actual movement of doing something where we're weight bearing, so they're not weight bearing as much. Okay, and then of course they use steroids. We haven't talked about medications, but we know that autoimmune diseases often are treated with steroids. So they get treated with steroids, that contributes to osteoporosis. Okay, so bone mineral density testing, which is what we do to diagnose and to monitor disease progression for osteoporosis, should definitely be done in this group of people. Okay, what's the word for bone mineral density testing? Does anyone know what the test is called?
DEXA?
DEXA, okay? So it's referred to as DEXA scan, D-E-X-A. Okay, so patients can become spastic, so they can have spasticity of their muscles, and then that can lead to contractures. So contractures, when literally you see this little skinny person, you guys have probably seen this in the hospital. You have a patient that can't weigh more than 100 pounds. They look like they have no muscle mass. They can't be very strong. They're contracted. You try to pull their arm, and you cannot move their arm for the life of you. Okay, that's a contracture. Okay, so people with MS can develop contractures. That's why it's so very important to prevent that from happening. Because once you have one, they're very difficult to get rid of. So if the patient can't exercise, then what's going to be very important for you to carry out as a nurse? Range of motion. Okay, extremely important. You do not want to have that patient that's in the fetal position on the bed, right, with their knees bent up and their arms like this, and they can't be moved. Okay, constipation. About half of people with MS will suffer from at least moderate constipation. Often it can be managed with diet, water intake, fiber, as much exercise is tolerated. Pneumonia, why is someone going to be at risk for pneumonia?
Waited one place. Being in one place too long?
Exactly, immobility. I mean, at this point, you know that immobility is one of the biggest places that we can make a difference in helping our patients be more mobile. We can prevent a myriad of problems. Okay, so as we said, relieving problems due to spasticity is going to be probably one of the primary nursing interventions. So we want our patient to move as much as tolerated, probably move them to the point just short of fatigue. Okay, that's really what we aim for. We don't want to get them fatigued, over fatigued. It'll take a long time for them to recover. But we really need to make sure that they stay as active as possible. Okay, bladder training. So when we say bladder training, what does that really mean? You hear that term thrown around, but what does it mean? Timing. Yeah, timing of what? Right, but also timing of intake too. Okay? So think about what you're giving to the patient, what time you're giving it, the amount that you're giving, and then trying to get them on a regular schedule with their bladder. Okay, so you know how much they're giving, you know when they should need to void, and then bringing them to the bathroom if they can't go themselves. Okay, so people that have MS are actually very sensitive to heat. So preventing increase of body heat will make them feel a lot better. Probably keep them more mobile, okay? Because if they're overheated, they're not going to want to move as much. Okay, diet. Now, diet for them is really a healthy diet for everyone. Like we said, we want to pay special attention to intake, oral intake of fluids, and also fiber. And if the patient has fever, they would be some people can tolerate a low fever, they don't really need to take anything. For these patients, antipyretics would be extremely important even if they have a low fever because of this inability to tolerate heat.
trigger it quickly if they were sweating and very, I mean, obviously their body would be sore, but heat would that trigger an acute?
It wouldn't bring on like an acute attack.
Oh,
It would just be that we'd be uncomfortable and then want to stop. That's
Oh,
all I'm saying.
oh.
It's not that it would bring on an acute. Okay, so patients may benefit from swallowing therapy. So I don't know, I think you guys have probably all seen this in charge. Patients can be referred to a swallowing therapist. These swallowing therapists may also, it's really speech and swallow usually I should say, so why don't you write that on there, speech and swallow, because they may really be beneficial to helping them with the dysarthria. Okay, so sex therapy, why do you think that's going to be necessary? Where's the problem here? Disease of what system?
Their nerves.
Nervous system. So they have disease of the nervous system, bowel and bladder issues, okay? So sex therapists may be extremely helpful for a patient in this situation. Okay, avoiding warm baths. So we always talk about our patients that are diabetic and have decreased feeling. So along the same lines for someone in this, or anyone who has really any sort of nerve damage, the warm baths can be dangerous to someone who has decreased sensitivity. What are other things along the lines of warm bath that we need to be careful with our patients if we do what to them? We put a hot pack on, we put an ice pack on. Anything where they have to be able to judge the temperature could potentially be dangerous. If they can't judge the temperature, we know that extreme temperatures can damage people. So if they can't judge that, we can't put something on them and leave them. Okay, so we need to have them thinking about that. What's a different way they can test the water before they get into the bath? Okay. And then of course being aware of pressure ulcers. So patients that are in a wheelchair, and this really goes for many people that are in a wheelchair, they have decreased sensitivity. They may not be aware that they have something starting until they get a pressure sore that's a stage 3. Okay, so we need to make sure that patient's skin is being assessed daily. Okay, so I worry most about the coccygeal area because that's very difficult, obviously, for the patient to see. And they're sitting in a wheelchair. That part is very exposed. So we want to make sure that they can do a good assessment there. So if you have an idea that they're not shifting in their seat, how often do we shift in our seat?
2 hours.
Okay, so we probably shift in our seat every like 15 seconds. I mean, quite honestly, when you think about it, you probably change some degree of pressure every few seconds. But yeah, we know that our patients that are sitting in wheelchairs that can't move themselves, the most amount of time they should be in there is 15 minutes. So if you think your patient's moving any less than that, they're at high risk for pressure sores. You really need to make sure that they are getting assessed daily. Okay, but they're very skinny, their whole spine too, along the edge of that wheelchair. Okay, elbows on the chair, on the armrest, so all that stuff has to be considered. Okay. Sorry, I noticed on your slide that you see. So pharmacologic, there are many medications. During an attack, patients will often be put on a course of steroids. Okay? And so just as an FYI, there's no cure. So these are all really supportive medications. Okay? So often they are to treat symptoms. Okay, so it's going to depend on what symptoms the patient is having. Okay, but across the board, if they're having an acute attack, no matter what their symptoms are, they may be put on a short course of steroids. Okay, so they will often shorten the duration of the relapse. Okay, anticholinergics may help bowel and bladder issues. Antidepressants, obviously for depression. A beta blocker. So beta blockers can decrease ataxia. Does anyone remember what the ataxia is? Like lack of coordination, movement. muscle relaxants. So baclofen is a muscle relaxant we may use. Also the benzodiazepines. We know that benzodiazepines often have what kind of effects? Also have what kind of effects? Sedative, anxiolytic.
Anxiety.
Yep, anti-anxiolytic. So the benzos may kind of go double fold there. So they can help decrease muscle spasticity, but also decrease anxiety. So if we can control both, that would be great with one drug. Okay, some people can't tolerate benzos, but most people can. You know, they're actually available in very small doses. Okay, anti-seizure medications. Anti-seizure medications have a myriad of effects too. So we talked about there being like 20 or 30 of them probably last week when we talked about seizures. And many of them are used for multiple things, so not just for seizures. Gabapentin is one that's used, which is Neurontin. You probably have a ton of patients on that. Or, you know, taking it 3 times a day. They take it for restless legs, they take it for neuropathy, they take it for seizures, they take it for MS. Okay, so anti-seizure medications may also help decrease ataxia. And then we have medications that actually modulate the immune system. And so these are things like Imuran, Cytoxin, Suboxone, Interferon. Most of these are injections that the patient gives themselves. Okay, and so these can decrease the frequency of relapse. So they're not always given, they will be given regularly. Okay, so they're to decrease the frequency of relapse, where steroids are given what? During a relapse. Okay, so don't go through the list and try to remember it. Just think about the symptoms, okay? And then think about what category of medications are going to target those symptoms. Okay, so impaired mobility. So I would say this is the big one when you're doing your reading. I want you to concentrate on the nursing interventions for all of these. Okay. So impaired mobility is something we really need to work with our patients on. Now, it's interesting because we're in the hospital. So like I said, most of the time patients are going to be admitted to the hospital. They'll probably have this in their history. They're usually not admitted for flare of MS. Okay, so I'll have this in their history, or if you're working outpatient, you may be doing assessments on people where this would be pertinent because you are questioning them about their lifestyle and their daily habits. Okay, risk for injury. What do you think puts them at risk for injury? Something we didn't mention, specifically, although you would assume this with ataxia, is that they can have a lot of gait problems. So if you have gait problems, what are you at risk for? You're at risk for falling. Okay? So I find that falling is really more concern, a bigger concern if you work in the city because our patients are able to go outside and do tours. If you have an 85-year-old in the suburbs, most, you know, they may have people coming to do things for them, but a lot of our 85-year-olds here are out on the street going a block to the market or what. They go in bad weather, they fall. Okay? They trip over the sidewalk, whatever. So we have a lot of falls here. These patients have osteoporosis. Okay? So there is for falling, there is for fractures. They're going to decrease sensation. So I mean that's a pretty big issue. And remember, you can always send your patients for physical therapy, specifically for gait and balance training. Okay, so keep that in mind. Gait and balance training is an appropriate referral for physical therapy. Okay, and a big part of it is giving your patients confidence. Because some of them fall once, they're scared. They don't want to go back out. Okay, so a lot of it is giving them the tools to go out. We want to keep them as active as we can without putting them at high risk. Okay, so impaired bowel and bladder function. So for, you mentioned interventions for constipation, I didn't know those already. And then for bladder function. So it may be catheterizing a few times a day, needed. Okay, it may be increasing fluids, it may be reminding the patient to be on a regular schedule with their voiding. Okay, and then sexual dysfunction, I would always refer to this. I don't think our training as a nurse really provides you with adequate tools to do counseling on sexual dysfunction. Be aware there's sexual therapists. The other thing that could be really good is there's also physical therapy for the pelvic floor. I don't know if you guys know about this, but there's specifically pelvic floor specialists, so they may be appropriate people to refer someone with MS to. Okay, do you know what the pelvic floor is? Anyone?
Exercise.
Kegels are like the only thing we know, right? About the pelvic floor. So it's like, were you gonna say something else?
It's like the same muscles that help with your urination or
Yeah.
controlling.
And sex and all that stuff. So all of that stuff that keeps everything in place. Okay, and that tends to go by the wayside, especially as women get older. Men too, men with the pelvic floor, gets less attention. But it's very appropriate that patients could benefit from a referral to a pelvic floor specialist. Okay, and there are places that do just that. Okay, any questions about MS? So I think a couple of things that aren't really in the slides is, first of all, the progression is generally pretty slow. So you get it from your about 20 to 40, and then usually they say you don't really have significant disability for another 15 to 25 years. Okay? But if you get it when you're 20 and you're 35 and you're significantly disabled, that's still young. But I guess it sounds, you know, I think people think once they have the diagnosis they're going to be in a wheelchair quite quickly, and that's generally not the case. Usually they have about 15 to 25 years before they have significant disability. Often patients do end up in a wheelchair though. Okay. And then one of the other big things is it's marked by these acute attacks. So most people are going to have periods of time where they progress to, where they, you know, have very bad symptoms, and then they tend to go back to their baseline. And usually the acute attacks, they don't happen within hours, or usually days to weeks that they come on. Myasthenia gravis is a neuromuscular disorder affecting the voluntary muscles. It's also autoimmune, and it's progressive. Okay? Also affects women more than men, and not hereditary. Okay, so when we say voluntary muscles, what are we leaving out? What's involuntary? GI, cardiac. Okay. So here, remember it's neuromuscular. So we have the nerve endings here, and then this is supposed to be a muscle fiber. Okay. And you have antibodies that bind to acetylcholine receptors, and they prevent muscle contractions. So what results is muscle weakness. Okay, voluntary muscle weakness, and that's the hallmark sign. Okay, so antibodies directed at acetylcholine receptors make fewer acetylcholine receptor sites. And you have impaired transmission of nerve impulses, and muscle contractions can't be sustained because this is where it hits. manifested by diplopia and ptosis. What's ptosis? Drooping the eyelid, okay? So patients can also have falls. They can have dysphagia and dysphagia. What's the difference?
Excessive hunger.
Yep, which one which? Did everyone hear that? Can you repeat it loud? I can't.
One difficulty of swallowing, another one difficulty of talking.
I love you.
Okay. And patients can have problems masticating, so that's chewing. So we say the word bulbar. You hear someone having bulbar symptoms, that means symptoms of the throat and face. Okay, so sometimes you'll hear that word bulbar in reference to myasthenia gravis. Throat. Bulbar. Okay. So diaphragm and intercostal muscles. So the intercostals are between our
Ribs.
between our ribs. So this can contribute to actual respiratory distress because those muscles are important for us breathing. So again, we can get dysarthria, we can have aspiration, and dysphonia. Dysphonia. It doesn't properly denote that, but that means hoarseness. Okay? So the thing here is it's relieved by rest. Okay? So weakness is the hallmark sign is relieved by rest. So patients can have what will often be seen as like a bland facial expression. Some people may think this guy's pretty pronounced. I would look at this guy and maybe think he has Bell's palsy or something. But really upon further exam, he has equal folds here. It's really just that his eye is drooping in this picture, but even he kind of has this bland facial expression. So some people may just think he's not interested, he's disaffected or whatever, but this is actually a hallmark sign. So that's with bulbar symptoms, facial and throat. Well, he probably has throat. We don't know. Okay, that's not just the face. He said they can also have limbs like muscles. Okay. So, but if you have problems swallowing the muscles in this part of your face, what do you think is going to be really important?
The diet?
Right. So, one of the big things is we need to make sure we give our patients their medications on time. Because what happens if we're late with our medications?
Can't swallow.
We can't swallow. Okay? So very, very important for them to stay on schedule with their medications. Because if we miss it, we're in trouble. Okay, so how do we diagnose? Okay? We can do a physical exam. We can get a history. We can do something called the tensilon test. And basically what we do is we give a patient acetylcholinesterase inhibitor. You know what? You should cross that out. Don't cross out ACH because it's not acetylcholine. Okay? So write in acetylcholine esterase. Okay? Okay, so this inhibits destruction of acetylcholine. So this is given, this medication is given, and if the patient has myasthenia gravis, about 30 seconds later, their symptoms will improve for about 5 minutes. Okay, now, so what's your next question? We don't use this for treatment every day. So, what's your question? Why not? Okay. So it can have side effects. So patients can have, it's on here. So patients can have bradycardia, sweating, and cramping. Okay, so sometimes they actually need to give atropine to combat the side effects. So it's really not appropriate to use every day. Okay? But that's the test, the tensilon test, is what may be used to diagnose myasthenia gravis. Okay? So also for diagnosis, we can do a test for antibodies. And we can also do an EMG to detect delay or failure of the neuromuscular junction. Okay, and we may do an MRI of the thymus. Does anyone know why we look at the thymus?
That's when your immune system matures
Okay.
and so becomes enlarged due to the autoimmune activity.
To rule out something else. So actually patients can have a problem in their thymus system. The thymus is actually where the acetylcholine receptor antibodies are made. So if they have something going crazy in this area, their symptoms may present as myasthenia gravis. Okay, so they may look at the thymus to see if they have a thymic disorder. Okay.
There's no one. Because that's where the ACH bodies are made.
She had colonoscopy because she has myasthenia gravis. Well, you can get so the biggest side effect of the common medication used to treat it is diarrhea. So I don't know if that was maybe they were concerned, maybe she was having it from the medication and then they were concerned that it could have been from something else. My patients who have had it have all been elderly and have had some degree of incontinence. Now, a lot of older females have some degree of incontinence as they get older. So, I think it is possible to have it. We have, voluntary sphincters. So, I think it's possible. I don't know that it's a hallmark sign of it necessarily, but yeah, I think it's possible to have that. But there's also probably other factors: age, the medications, if it's fecal. Okay, so medically, what do we want to do? We want to reduce the circulating antibodies. And again, unfortunately, there's no cure, only treatment, okay, just like MS. So, mestinon is the most commonly used medication. Sorry, there should be a parentheses after bromide. Okay, so mestinon is the brand name, and the word after that, which I will not try to pronounce, is the generic name. Okay, side effects include diarrhea, fasciculations, muscle fasciculations, and oropharyngeal secretions. Immunosuppressive therapy. So again, it's immune, we're working on the immune system. So we can give steroids, prednisone. Okay, and we may give Inuran or IVIG with severe forms. Okay, what's IVIG? Okay, so it's intravenous immune globulin, pooled human gamma globulin. Flash, there's a slash in there. Okay, so it's IVIG syndrome, intravenous immune globulin. And immune globulin is human pooled gamma globulin. Okay. With Imuran inhibits lymphocytes. Okay, what I want you to know with Imuran is it may take a few months to see results. Okay? And so what are some of the immune immunoregulatory drugs do. They can suppress your immune system, so you may see a serious side effect of very low white blood cells. So you can have very low leukocytes. Okay, so that's something important I want you to know about Imuran. So if you have very low leukocytes, what are you at risk for?
Infection.
Infection. Okay, what are you at risk for when you're on prednisone?
Infection.
Infection. Okay, we're going to talk, when we talk about Guillain-Barré, we will also mention this word plasmapheresis. So with plasmapheresis, you have your plasma is actually removed via a catheter, okay, and they put the plasma through a system that removes the antibodies, and then they return the plasma without the antibodies to the patient. Okay, and this may be done daily or every other day. If they think the problem is with the thymus gland, they may do a thymectomy. So this can decrease signs and symptoms, but it can actually take several years to see this decrease in signs and symptoms because antibodies have extremely long half-lives. Yep.
I don't remember if you mentioned this or not, but how long do the flare-ups usually last?
Well, it's not as much of a flare. When you think about flares, they're really more like beginning and end with MS.
Okay.
Yeah. So this isn't as much marked by flares. Okay. So this is important. Patients can go into something called myasthenia crisis. Okay? And so some people may refer to this as a flare, but I would really say this is different. Usually this crisis is brought on by something particular. Okay? So this is a severe episode of symptoms, usually triggered by infection, emotional stress, or just not taking the medications. Okay? So that's different than MS, where it can just kind of come on for really no identifiable reason. Okay? So there's a reason that it happens. So these crises, these myasthenia crises, can be life-threatening due to respiratory failure. So remember, it's affecting our diaphragm, it's affecting our intercostals. So the interesting thing here, though, is we talked about this phenomenon before. Often we give medications, and the medications can do the same thing that the problem caused us in the first place, right? So we have that same phenomenon here where we can have what's called a cholinergic crisis. So cholinergic crisis means we get an overdose of the medication. We get too many medications, and you can actually have the same symptoms as myasthenia crisis, but there's one difference, and you'll have diarrhea, because you'll have diarrhea with this cholinergic crisis, okay? Remember, the main side effect of Mestinon, like I said, is diarrhea. So myasthenia crisis, cholinergic crisis, the symptoms are the same. Myasthenia is usually due to not taking meds. Cholinergic crisis is usually due to too many meds. The difference between the symptoms will be diarrhea with cholinergic crises. So it is a normal side effect. It's going to depend on a couple things. How bad is it? Okay, can the patient tolerate it? Are their electrolytes stable? What I've seen usually is that they decrease the Mestinon, and most patients still tolerate it. So they'll have loose bowels. A lot of these people aren't, a lot of these people tend to be older, and they're kind of at home, so it's not as much of an issue. If you have someone who's younger and working, or whatever, that would be more of an issue. But from what I've seen, they've decreased the dose, and they've been able to tolerate it. Okay, so respiratory failure is the critical complication for both of these. Okay, and so patients may need mechanical ventilation. Okay, often in these situations, they'll give plasmapheresis or IVIG. Okay, so like I mentioned, medications given at the exact time is very important. So muscle weakness will make it difficult to swallow. secretions, we said oral pharyngeal secretions are a commonly seen symptom. So they may need to be managed by nurse if your patient needs to be suctioned. You know, many people will be able to manage their own secretions. What do we want to do? We want to make sure the patient's hydrated so the secretions are thin. Okay, so there are certain medications that can actually trigger crisis, myasthenia crisis. So Novocaine and some antibiotics, not all, cardiovascular and psychotropic drugs can trigger crisis. So any of these medications should be discussed with the neurologist. So when would this be important? So if patients on a neuro floor being taken care of by a team of neurologists, they probably know this list of medications. But you as the nurse are taking care of a patient, you're on a psych unit or you're in a cardiovascular unit, and this patient has myasthenia in their history, they're not admitted to the hospital for it, they're being cared for by a bunch of cardiologists, okay? These cardiologists probably aren't gonna know that the medication they may prescribe could trigger a crisis, okay? So something for you to think about, you to say, should we check this with the neurologist? Are there any, is that a possible side effect of this medication? Okay, so we all get very embedded in our specialty of where we practice, and you have to remember that the patient is not just a cardiovascular patient. Okay, they may be there for a cardiovascular reason, but they have another whole set of issues that need to be thought about. So we have to remember our patients, think of our patients as a whole patient, not just a bunch of diseases. Okay, so people, like I said, in a specialty know their specialty really well. They may not know everything else. It's our job to make sure that that patient gets appropriately treated. So the thing to do would be to call the neurologist and run those medications by the neurologist. So we want to protect the eyes. Some patients may have difficulty closing their eyes all the way. So when they have difficulty closing their eyes all the way, we may teach them to tape their eyes at night, okay? And that's going to prevent dryness. Energy conservation. So we want to teach our patients to do activity sort of at the peak of their energy. Okay, so most people will know when they have the most energy. Some may be right when they wake up in the morning, some may be early afternoon after they take a nap. Okay, but they have to be aware of their circadian rhythms here. Okay, nutrition. We mentioned eating before, I think, Patrick. So meals should be given at peak time with medication, okay? Because remember, we're concerned about, swallowing. Okay, so if the patient is in crisis, then the focus will be on respiratory management. If the patient cannot swallow, tube feedings may be needed. We're going to bypass the part of the problem, part of the GI system that the patient is having a problem with, and the patient will have a tube feed drawing instead. So we want to avoid medications that can cause respiratory depression, okay? So sedatives, tranquilizers, what else? What's the one we use all the time?
Analgesics.
Sarah?
Analgesics or like.
Yep, analgesics, right. So
Jesus.
narcotics, we're really concerned about giving them respiratory depression is the most concerning side effect of opioids.
Opioids, there we go, that's the word.
Okay, patient may need an ABG, they're acidotic, electrolytes, daily weight, and iron order. Can be very helpful. We know they have increased secretions and not as much mobility in their chest. Their muscles are weak. They probably can't cough as well. They can't maybe do deep breathing. So chest PT may be ordered to mobilize their secretions. Okay, so sorry, I just need like a 5-minute break for my voice, and then we'll start again. So it is 3? Yeah. Okay, so we'll start again in 5 minutes, okay?